Welcome to Section 1 of Respiratory Embryology. Before we dive into respiratory development, let's get an idea of the final product. This picture contains some of the major structures of the respiratory system. As the lungs develop, they will undergo successive rounds of branching from a single tracheal tube to primary bronchi, into smaller bronchi, then to bronchioles, and then alveoli, which you can see over here. So with this basic overview, let's discuss the stages of lung development. Lung development is classically divided into 5 stages: the embryonic stage, the pseudoglandular stage, the canalicular stage, the saccular stage, and the alveolar stage. You can remember these stages with the mnemonic, "Every pulmonologist can see alveoli." The first letter of each word corresponds to the stage in development. This image depicts the 5 stages as they actually appear. We have the embryonic stage, the pseudoglandular stage, the canalicular stage, the saccular stage, and the alveolar stage. And again, to remember the order of these stages, just think, every pulmonologist can see alveoli. Now let's cover each stage individually, starting with the embryonic stage. Here's the embryology overview figure described in the first section of reproductive embryology. At the bottom, we have a depiction of the fetus from a lateral perspective. Now the development of the respiratory tree actually starts with the foregut, which would be in this area. But let's focus on exactly how the foregut leads to the development of the respiratory tree. Well, in the embryonic stage, which is weeks 4 to 7, there's something called the respiratory diverticulum, which branches off from the foregut. Once branched off, the trachea develops, and then the esophagus from the foregut also develops. So you end up getting an esophagus and a trachea that are separate. The image on the left shows a lateral view of the fetus when the respiratory diverticulum is forming, and you can see it branching off of the foregut, which is this area that I've outlined in blue. The image on the right shows the foregut and the respiratory diverticulum branching off from it. Gradually, the esophagus and the trachea separate, and the trachea gives rise to the lung buds. So we go from respiratory diverticulum to the trachea to the lung buds. Now in the embryonic stage, if there are errors, this can lead to tracheoesophageal fistulas, a TEF, and or esophageal atresia, EA. This image depicts tracheoesophageal fistulas, esophageal atresias, and a combination of the two. Now, esophageal atresia is when the esophagus ends in a blind pouch, as pictured here. It's just this blind pouch. Or you can have just an esophageal atresia, or there can be a tracheoesophageal fistula, which is a connection between the two. This would be called H-type because it forms the shape of an H. So now that we've discussed esophageal atresia and tracheoesophageal fistula, it's important to know that you can have a combination of the two. So you can see this blind pouch here indicating esophageal atresia, and you can see the fistula connecting the lower esophagus to the trachea. Now this is the most common type. It actually occurs 85% of the time. Now let's talk about the clinical signs and symptoms of the different tracheoesophageal anomalies. In the newborn with esophageal atresia, you will see drooling, choking, and vomiting on the first feed. And that's because the newborn is unable to swallow their saliva into their stomach. In utero, you will see polyhydramnios, which is excess volume of amniotic fluid. And this happens because the fetus will be unable to swallow the amniotic fluid due to the esophagus ending in a blind pouch. So the amniotic fluid just builds up outside the fetus. Now, if a tracheoesophageal fistula is present, then gastric distension will also be present and seen on X-ray. This, of course, would be absent in a baby with a pure esophageal atresia because the esophagus ends in a blind pouch and no air can get into the stomach. So dealing with just an esophageal atresia means that you won't get air from the trachea entering the esophagus. It just doesn't happen because there's no fistula. So gastric distension is possible with a tracheoesophageal fistula. It's not in an esophageal atresia. Another thing that can happen with a tracheoesophageal fistula is that babies can have reflux that enters their respiratory system. This leads to aspiration pneumonia. As a result of this, the patients can have cyanosis, which is secondary to laryngospasm. And aspiration of these gastric liquids can lead to laryngospasm, which then leads to cyanosis. Now let's talk about the diagnosis and treatment of these conditions. In the case of esophageal atresia, or a combination of esophageal atresia and tracheoesophageal fistula, the diagnosis is having the nasogastric tube failing to enter the stomach. And the reason this would be is because esophageal atresia ends in a blind pouch. So if you put a nasogastric tube down the esophagus, it'll just hit a dead end and not be able to continue. And if that happens, you've got your diagnosis. And the treatment is fairly straightforward. It's surgery. So going back to this image, if you have a nasogastric tube, it'll just hit a dead end. Same thing over here. Now, if you have a pure esophageal atresia, the H type, because it looks like an H, the diagnosis is just visualized using fluoroscopy. This is basically an X-ray done with dye, and it can highlight the fistula. And the treatment for any type of esophageal atresia or tracheoesophageal fistula is surgery. Now, coming back to this image, we see that the respiratory diverticulum should branch off and eventually separate, leading to a separate esophagus and trachea. But there's another problem that can occur during lung development. In fact, there's these little cysts that can form and bud off of the foregut. These are called bronchogenic cysts. These occur as a result of abnormal budding of the foregut. They are usually found along the mediastinum because they bud off of the foregut just like the lung bud, the respiratory diverticulum. The condition is typically asymptomatic, and the cysts are usually filled with respiratory epithelium and cartilage. Now, we mentioned that it's typically asymptomatic. However, the cysts can potentially compress the airway if they become too big or if they become infected. So, with that respiratory epithelium and cartilage, they are technically fluid-filled, but if they become infected, they will be air-filled. So, although they're typically asymptomatic, it's obvious that they can be infected and cause problems. And when they get infected, they actually are poorly draining. In other words, you can't drain the cyst easily. Now that we've covered the embryonic stage and its related pathologies, let's move on to the pseudoglandular stage of lung development. The pseudoglandular stage occurs during weeks 5 to 17. During this time, normal respiration is still not possible. So at this stage, the fetus is incompatible with life. And during this stage, the terminal bronchioles are formed, and so there's a modest capillary network. And fetal respiration actually becomes important, which sounds strange because they're not able to respire in the way that we think of. Well, what happens is they actually aspirate small amounts of amniotic fluid. And they need to do this, and that's because this fluid coming inside the growing bronchial tree presents this pressure pushing outward, which stimulates lung growth and development. So in other words, the fetus must be able to inhale amniotic fluid to help the lungs grow. If there's a failure to aspirate this amniotic fluid into the growing lung tree, then the patient can have pulmonary hypoplasia, which again is poor development of the bronchopulmonary tree. And the main two reasons causing this are Potter's sequence and diaphragmatic hernias. In Potter's sequence, there's a renal issue, which leads to decreased amniotic fluid, which leads to decreased aspiration of amniotic fluid. And this would lead to pulmonary hypoplasia. Potter's sequence is described in more detail in renal embryology. Now let's describe diaphragmatic hernias. This occurs when there is a defective formation of the pleuroperitoneal folds, leading to herniation of abdominal contents into the pleural cavity. And if the space that should be available for the developing lung is actually taken by abdominal contents, then the lungs will not be able to develop fully. This image shows an axial cut through the thoracic cavity, and we can see the heart right here. And the lungs appear black because they're filled with air. The abdominal contents should not be seen here in this cavity, yet we see the stomach right here, indicating a diaphragmatic hernia. So naturally, these lungs will not be able to develop fully. Now let's move on to the canalicular stage. The canalicular stage occurs between weeks 16 and 25, and it results in the formation of respiratory bronchioles and alveolar ducts and a more robust, stronger capillary network. And during this stage, type 2 pneumocytes and begin producing surfactant. And this decreases surface tension and allows the alveoli to expand. Type 2 pneumocytes and surface tension and alveolar expansion is discussed in more detail in respiratory physiology. But what you need to know about this stage is that because of the formation of the respiratory bronchioles and the alveolar ducts, respiration is possible. So the fetus is considered viable at this stage. Now let's move on to the saccular stage. During this stage, the terminal sacs form, and these are considered primitive alveoli. And they are said to have primary septae because they have not yet separated into mature alveoli. So at this stage, you can think of these terminal sacs as big grapes that haven't yet separated. But in the last stage, the alveolar stage, we get the secondary septae. So you get what look like actual grapes. So these are adult alveoli. So again, you get adult alveoli. They have these secondary septae. so you can think of grapes. So at birth, we start with about 35 million alveoli to about 350 million alveoli by the age of about 8. It's about a 10 times increase. And if there's a disruption at any point, then there can be bronchopulmonary dysplasia. The good news is that alveolar development in this alveolar stage continues until about 8 years old, as I just mentioned, which means that even if the patient does have bronchopulmonary dysplasia at birth, they can continue to develop their alveoli and symptoms can improve. Now that we've discussed all 5 stages and some of the pathology that can occur at certain stages, let's do a question to apply what you've learned. A newborn baby is born with flattened facies and club feet. On further inspection, it is found that the baby has pulmonary hypoplasia, which disturbance in lung development would most likely lead to the symptoms described. A. Abnormal budding of the foregut. B. A diaphragmatic hernia. C. Polyhydramnios. D. Failure of trachea to separate from foregut. Or E. Renal agenesis. Hopefully from the question stem, you noticed the flattened facies, club feet, and pulmonary hypoplasia. All of these are symptoms of Potter sequence, also called Potter syndrome. The inciting event leading to Potter syndrome or Potter sequence is a problem excreting urine into the amniotic fluid. And of these 5 options, the only option that describes this is renal agenesis, which is choice E. A is incorrect because abnormal budding of the foregut causes bronchogenic cysts, not Potter sequence. And choice B is wrong because diaphragmatic hernias cause pulmonary hypoplasia, but none of the other symptoms. In other words, a diaphragmatic hernia doesn't explain the flattened facies or the club feet. Answer C is wrong because polyhydramnios is too much amniotic fluid. And when you're dealing with Potter sequence, we're dealing with too little amniotic fluid. Finally, choice D is incorrect because failure of the trachea to separate from the foregut results in esophageal atresia and or tracheoesophageal fistula. It does not cause Potter sequence. So again, the only answer that leads to Potter sequence is choice E, renal agenesis. And that concludes this section.